Hello everyone, today we discuss retained placenta, an important obstetric emergency that we all have to be aware of if we are to work in any labor ward. So retained placenta occurs in 3% of all vaginal deliveries. That is a lot of retained placentas, considering how many deliveries we have every day around the world. 6 to 20% of all these postpartum hemorrhage cases we see are a result of retained placenta. And in the developing world, retained placenta has a high mortality. That is as high as 10%, meaning that 1 out of 10 retained placenta patients end up dead. And as usual, we start from our terminology. What is a retained placenta? A placenta is said to be retained when the placenta is still in the uterus 30 minutes after delivery of the baby. That definition holds if there was active management of the third stage. If the management of the third stage was physiological, normally people would go as far as 1 hour to call something a retained placenta. But that's not the only definition of retained placenta. Sometimes it's defined as excessive bleeding, of course, when the baby has been delivered and the placenta is still in situ. We recognize that in this definition, there's no time allocated. The issue is that the patient is still bleeding, or the patient has started bleeding and the placenta is still in situ, even when the 30 minutes landmark has not elapsed. The last definition of retained placenta is that you have a part of the placenta that has remained. Part of it has been removed and part of it has remained. This may happen in a case of a patient having a succensurate lobe and the bigger part of the placenta has come out and the smaller succensurate lobe is still there. So that is still a retained placenta. So there are 4 stages of placental delivery. The first stage is just after delivery of the baby. The placental bed or the muscles of the uterus overlying the placental bed do not contract. They're in the quiescent stage, probably because of the progesterone concentration in that area, nitric oxide concentration in that area. They do not contract. They're in the quiescent stage. After a few minutes, we enter into what is called the contraction phase. So in this contraction phase, the uterus or the muscles of the uterus overlying the placental bed contract strongly, and then this leads to shearing off of the placenta from the wall of the uterus. This is the place where there's a problem when you have an ACCRETA, because even after the uterus contracts, there's no shearing off of the placenta from the uterine wall. Then the third stage after the contraction, of course, is detachment, and after detachment there is now contraction of the whole uterus to actually expel the placenta. And in cases of trapped placenta, the uterus can contract in such a way that there's a ring around the cervix and the placenta gets trapped and fails to come out, even if it's been detached. So that is how the placenta gets out, and those are the stages of placental delivery. So if this doesn't happen within 30 minutes, it's been noted that that's when the risk of postpartum hemorrhage increases, and that's why most people define a retained placenta as a placenta that has not been delivered by the time 30 minutes time mark has elapsed. So it is for the reasons explained in the last slide that we are advised in the active management of the third stage of labor not to put traction on the cord, not to pull on the cord before the contraction comes. Because after the contraction has happened, the contraction of the uterus has happened, there's blockage of those blood vessels, the ACCRETA arteries, the radio arteries. They are blocked by the contraction. And therefore, once we pull on the placenta and it gets detached completely, there's minimal bleeding. But if we pull on the placenta before a contraction and before the contraction phase of the stages of placental delivery, then those arteries are still open and we end up with a patient bleeding and eventual postpartum hemorrhage. So there are three causes of retained placenta. The first one is placenta adherens, the next one is placenta accreta spectrum, and the third one is a trapped placenta. So placenta adherens is the most common type of retained placenta. In this case, what has happened is that the uterus has failed to contract on the placental side, so the placenta is just slightly attached to the wall of the uterus. In a morbidly adherent placenta, or otherwise called placenta accreta spectrum, the chorionic villi have invaded the myometrium, and therefore the placenta is adherently attached to the uterine wall, because we know that the chorionic villi should just go as deep as the decidua of the of the uterus, but in this case they've gone through the myometrium, and therefore the placenta is very strongly attached to the wall of the uterus. The last one is a trapped placenta. A trapped placenta is a detached placenta. It's completely detached, but there's a ring around the cervical isthmus, and therefore the placenta cannot come out. So that is what is called a trapped placenta. So we move on to the risks of the of retained placenta. So the risks of retained placenta are those things that can cause a trapping of the placenta, those things that can cause placenta accreta, those things that can cause placenta adherens. So those are the risks. So this includes use of oxytocin, because use of oxytocin can cause closure of the cervix before the placenta comes out. Multiparity is a risk because it causes atony, of course, and lack of contraction of the placental bed. Prematurity, a premature placenta is not well developed to detach properly. History of a previous retained placenta, we've heard that if when a girl is born, there's a genetic predisposition as well, because when a girl is born and during her own delivery the placenta was retained, then she's likely to have a retained placenta when she delivers herself. Previous uterine surgery, in vitro fertilization, previous scissors, and things like placenta previa and implantation of the placenta in the lower uterine segment where there's not so much muscle, so the placenta actually goes a little bit into the myometrium and is more difficult to extract. So those are the risk factors. So how do we manage a retained placenta? So normally people wait for 30 minutes before they interfere, but there are many others that wait for 60 minutes, because between 30 and 60 minutes, about 40% of placentas actually come out by themselves. So if there's no bleeding, we can wait up to 60 minutes, but there are some schools of thought that start manual removal of the placenta at the point where we exceed 30 minutes. Then we have to remove the placenta manually. Once we make that diagnosis, we need to explain to the patient the condition and the need for theater. If the patient is bleeding, we need to make sure we do our ABCs, the airway, the cannulas, the IV fluids, and so on. We look for blood, all those things. And when we're removing the placenta, we have to have the patient in a good position That is usually lithotomy. We have to have good lighting, and of course we have to know what we are doing. We have to give patient analgesia. In our setting, normally we would give maybe pethidine and diazepam, because it's so difficult to get to theater in our setup. It will take you 1 hour, it will take you 30 minutes, it will take you 2 hours to get to theater. So most of the time these procedures are done on the ward, so we need to make sure we put on sterile gloves. We wash our hands, because the risk of endometritis is high with these manual removals. And then we put the patient on antibiotics, and because of this risk of endometritis, and we have to try as much as possible to remove the placenta as a whole and inspect it after removal. I've put this picture on the left to just demonstrate that you have to go in between the uterus wall and the placenta and just try to cleave it off the wall as a whole, and your guide is the cord to get you to the placenta. So follow the cord, gets you to the placenta, to the placental edge, cleave the area, separate the wall, the placenta from the wall of the uterus, and then the placenta comes out. That's how this is done. So you can imagine that this is a painful procedure, and the woman needs to be under anesthesia ideally, but good analgesia does the job in most of our setups where it's really limited theater space and delays and so on. So it's difficult to get the patient to theater in our case. So if active management of the third stage of labor has been done, people have waited for 1 hour, the placenta is not coming out, manual removal has been attempted, the placenta seems to be coming out in pieces, it's better to make a diagnosis of placenta ACCRETA and advise the patient for hysterectomy, because now we are going into an area where we might have a patient dying from postpartum hemorrhage. So we cancel the patient for hysterectomy and take the patient for hysterectomy. The difficult part arises if the patient, because of maybe unsatisfied parity, they don't want to go for hysterectomy. There the problem comes in, because then we have to try and remove the placenta in pieces, try and get some maybe manual vacuum aspiration done, or curating done after the placenta has been removed in pieces. Maybe we can put a balloon tamponade to also help with hemostasis. That's one way to handle this problem. Then another way, if we have had the placenta that has not really been tampered with, and the placenta is still in situ, the patient is still stable, she's not bleeding, the placenta is still strongly adherent to the uterine wall, there's room for conservative management. We can just leave the placenta in situ, monitor the patient, and eventually the placenta gets reabsorbed. Sometimes we can use methotrexate to help with placenta resorption, but all these medical management or conservative management might end up with a patient bleeding. So the patient has to be aware that the plan might change to hysterectomy if anything changes when we are doing conservative management. We also have to choose the correct patient, the patient who understands the condition, the patient who lives near the hospital, the patient who has access to the hospital, if we are going to manage these conditions this condition conservatively. So we have to pick our patients, and the treatment should be individualized. We'll be doing beta HCGs to monitor the resorption of the placenta, because as the placenta dies out, the amount of beta HCG becomes negative. And lastly, I'll talk briefly about medical management of retained placenta. And this has been widely studied. People have tried to give oxytocin through the umbilical vein, tried to give oxytocin as an infusion after a retained placenta. The problem with medical management of retained placenta is that we really don't know what has caused a retained placenta. Is it a trapped placenta? Is it placenta adherens? Is it placenta ACCRETA? We don't know. So if we give oxytocin in a placenta ACCRETA, we are really just delaying the management of this patient, and we might be in trouble. If we give oxytocin in a trapped placenta, of course the placenta gets even more trapped. Maybe oxytocin only helps if the diagnosis is placenta adherens, because in placenta adherens, the problem is that the uterus hasn't contracted enough to make the placenta detach. That's the only one where that would probably work, but we don't know. So medical management is really discouraged. Whenever we have a retained placenta, we have to go in manually, because if you have a condition like trapped placenta, what you really need is a muscle relaxant, maybe nitroglycerin. If the patient is in theater, the anesthetist can give halothane, something that will relax the uterus, and the hand easily goes in and gets the uterus out. The only role of oxytocin in the management of retained placenta is after we have removed the placenta, we have to give all the oxytocic agents that we have. We give our misoprostol, we give our tranexamic acid, we give our oxytocin, all those drugs that we have to help the uterus contract now because the placenta is out, and then help to achieve hemostasis. The other role of oxytocin is maybe somebody in a rural health center and they have a retained placenta and the patient is bleeding, so they're trying to move this patient to a tertiary institution. So in that case, we can give oxytocin so that we help contract the uterus and help reduce the bleeding. Otherwise, we do not give an oxytocin infusion in somebody who has a retained placenta. We just manually remove the placenta. And we've mentioned here and there in this presentation on placenta ACCRETA, but that wasn't the purpose of this presentation. Suffice it to say that sometimes in the developed world, people diagnose a placenta ACCRETA before delivery or in the antenatal period. In our setup, that rarely happens. We just get to know about placenta ACCRETA when the mother has already delivered. So maybe we can talk about how to properly manage placenta ACCRETA as a subject on its own in our other presentations. So thank you so much for listening, and we will see you in the next presentation.